Purva, shall I start? So, good evening to all of you. Can you see my slides? Hello?
Yes, sir. Yes, sir.
Yeah, right. Okay, right. We'll start with a short case first. This is a common problem which we deal with every day. This is a story of a 17-year-old man. He presented with the history of memory loss and walking difficulty for the last 2 years. Was being treated for Parkinson's disease with high dose of levodopa. He came with a complaint that he was not improving with the medication, that he sought a second opinion. This is the gate to the patient.
അച്ഛാ നടന്നോ 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 നടക്കേ നോക്കട്ടെ പിന്നെ തിരിച്ചു നടന്നേ അച്ഛാ തിരിച്ചു നടക്ക് തിരിഞ്ഞ് നടക്ക് നടന്നോ ഓക്കെ നടന്നോ ഞങ്ങളൊക്കെ നിപ്പുണ്ട്.
Marked start hesitation and slow, slightly broad-based gait.
നടന്നോ വാ.
Okay, what is your likely diagnosis in this patient?
The patient has got an ignition failure, sir. Start hesitation.
Yeah,
Patient
right.
has start hesitation, ignition failure. It's a broad-based gait.
Yeah.
It's grossly bradykinetic at the same time, turning difficulty. So
Right.
likely to be a frontal gait disorder.
Perfectly right. So most likely cause would be NBH, no?
Yes, sir.
So let us see the MRI in this patient. See the MRI now. Ventricular dilatation, some seepage, and marked cortical atrophy. So it shows deep sulci there on both sides. That is a degree of atrophy there. I will show the T2 sequence, coronal sequence. Is the widened sulci. See the cortical sulci there widened. That's another deep sulci. So, what would you like to do in this patient?
Shunt the patient.
First, CSF studies. CSF will draw CSF and see the response first.
Okay. But do you expect to be improved with such a severe degree of atrophy of the brain?
Unlikely. We don't know. But it may take long time, sir.
Okay. But still you want to try CSF tap, no?
Yes, sir.
Okay. So after CSF tap,
അറ്റം വരെ പോയിട്ട് വാ. പിന്നെ തിരിച്ചു വാ. പിന്നെ തിരിഞ്ഞ് okay.
This is 1 week after the CSF tap.
Speed നടക്ക്.
Definitely better.
Definitely better. Now, how did he improve then with that degree of atrophy?
Sir, he has got a dash.
Yeah, that's the thing. What I told atrophy was not really atrophy at all. That's the reason why I brought this case. So this is this dash called disproportionately enlarged subarachnoid hydrocephalus. I'll explain it later on. Now, CSF volume gets significantly increased in the sylvian fissure, but decreased in the superior convexity and medial subarachnoid spaces, in addition to ventricular megaly. This includes tight, high convexity, enlarged sylvian fissures, and entrapped cortical sulci. These pockets of CSF accumulation indicate disruption of CSF absorption. This is a classical dish. The criteria is one is that, if you look at the atrophy, there is no atrophy of the superior part of the convexity of this thing. The ventricle is dilated, sylvian fissure is increased, and a tight, high convexity. That's an important point to show shunt responsiveness, response to CSF tab. If you find like this, you might think there is a cortical atrophy, sulcal hypertrophy. Actually, they are fluid pockets of fluid collection in the cortical side. Fluid tends to accumulate not only in the Cillian fissure, but also in other major fissures, example calcarine, parieto-occipital, longitudinal fissures, and connecting sulci. They can be mistaken for atrophy or arachnoid cyst when viewed only on one out of three anatomical planes. These are examples, prominent Cillian fissure. And this, what you show on the right side, is a enlarged CSF space in the sulci. And this is the tight convexity. In the Alzheimer's disease, the tight convexity is not seen. This is NPH with a dash. On the right side is NPH patient without features of dash. Without features do not improve not improve very well. Those with the dash are the one which improve remarkably with the CSF tab. So even if there is some degree of cortical atrophy, if you find dash there, even with the patients of 79-year-old or 80-year-old, that patient merits a CSF tab. Among all the tests, the most useful to predict the shunt responsiveness is a tab test. Other investigators which can predict shunt responsiveness include TESH. The estimated positive predictive validation for shunt responders is 77%. But remember the other test, like say for example, the wide callosal angle or acute callosal angle, the Evans index of more than 0.3 and the CSF pace around the lateral ventricle, they are not at all highly predicative of improvement with the CSF shunt or the CSF tab test. This is one thing you should always look for, the prominent subarachnoid CSF spaces and the pockets of CSF collection, as well as the prominent Cillian fissure in the presence of a tight superior convexity. So that's the idea of bringing this case. So any questions?
Sir, how many taps were done? Single tap or three
No,
taps?
here and I usually do 3 taps. Consecutive. The thing is that sometimes the patient may not improve after 3 taps, only show mild improvement. But over a period of time, 1 to 2 weeks time, the patient improve. Classical teaching that even if within hours the CSF will reaccumulate. It is something beyond the reaccumulation CSF which is causing this one. Why should the patient improve after 2-3 weeks later? Same thing with CSF shunt also. Immediately after shunt, patient may not improve. Improvement comes after 2-3 months later. So some other mechanism is operating rather than just CSF accumulation.
Sir, any experience with a lumbar drain continuous?
No, I never tried lumbar drain. No, nowadays nobody educate lumbar drain because of the high chance of intracranial infection through the lumbar drain.
Okay, sir.
Okay, shall I go to the next case? Okay. Yeah. This is a story of a 52-year-old female. She was a known case of hypertension and carcinoma breast. On both sides. Initially in 2004, it occurred on the right side. In 2024, 10 years later on the left side, both were operated and completed chemotherapy by February 2025. She came with a complaint of pain in the left buttock region 3 weeks back, which were in episodes lasting for a few minutes. This was followed later by pain over both calves, for which she consulted local hospital, and she had taken some painkillers and was initiated on physiotherapy, maybe thought this perhaps. On the second day of physiotherapy, her symptoms worsened. Later that day, she noticed slight difficulty in walking and had numbness of both feet. Next day morning, she noticed weakness in the form of difficulty to get up from bed. However, she was able to sit up on the bed but not able to stand on the ground without support. She later went for Ayurvedic treatment due to the above complaints, and the symptoms gradually worsened over days. 1 week later, she noticed numbness of both legs from hip downward up to the both feet. Numbness over the buttocks region, left more than the right. Later on, she noticed buckling of the knees and could walk only with the help of a walker. Over the past 1 week, she also noticed difficulty in initiation of urine, difficulty in urination, as well as incomplete voiding. For the last 2 days, she has weakness further worsened and bedridden. So over a period of, total duration is about 3 weeks duration. But 3 weeks, then weakness, progressive weakness and numbness. Then she became bedridden and subsequently bladder involvement in a nutshell. More like an element because of the proximal muscle involvement initially. Okay, let us see. Now this is examination finding. This is not a good video because this is taken by my MD PhD student when I was examining. Her upper limbs were normal. No complaints pertaining to the upper limbs. I'll just show that. Power was normal. This one lying down, her tone was hypotonia in both the lower limb. Hip flexion was about 3 on the right side, 2 on the left side. She cannot lift up the left one. Right hip flexion was about 3 plus to 4. Is 3 only. Left side and left hip flexion is, she cannot even keep his leg leg flex. It drops down. Knee extension is also grossly weak, not even 2. On the right side, knee extension is about 8 to 4. Really good part on the right side. Close flexion is good on the right side, about 4 plus, 0 on the left side. HL was weak by left. Plantar flexion on the right side is weak. See, she could not do the plantar flexion properly. But dorsiflexion was good. Good dorsiflexion, but markedly weak plantar flexion on the right side. Left side dorsal plantar, everything was 0. Hip abduction is weak, bilaterally more weak on the left side than the right side. The right side she can offer some resistance. Extension also weak on the right side, but more weak on the left side. Reflexes, both knee and ankle joints were absent. Plantar was mute. And I think the sensory examination you couldn't hear. She had impaired touch and pain over the lateral side of the leg and the dorsum of the foot and plantar surface. Medial leg was spared. Medial part was spared, lateral was affected. Somewhere around the phase 1 dermatomal distribution. She will tell when it is more. When it reaches the knee, she is able to feel the pain. There she is able to feel on the shin, the middle part of the shin. There is no difference between both sides. She is able to feel the vibration on the right side, on the shin, not on the left side. And the vibration impaired in both feet. She is able to feel over there, but not on the right side, not on the left side. There she is able to feel on the iliac and iliac. Joint sense is impaired or both ways. Okay, summarizing the findings. Findings confined to both the lower limb. Left lower limb power, all proximal muscles including hip flexion was grade 2. Knee extension flexion grade 3. Distal muscles 0 to 1. The right lower limb, hip flexion, extension, abduction, adduction about 3 plus to 4. Knee extension grade 4 plus, knee flexion grade 4. But dorsiflexion AHL was grade 4 plus, but plantar flexion was more weak than the dorsiflexion, grade 2 to 3. DTR absent in both lower limbs, plantar mute. Sensory system impaired pain and touch over the lateral leg, dorsum and sole of both legs, normally felt over the medial part of the shin. Vibration is lost in the lower limb below the knee. On the right leg, vibration is preserved over the medial shin, lost in other areas of the leg. JPS impaired over both toes. SLR is negative. Patient could not stand without support. This is the area of sensory loss on both the lower limb, anterolateral part, as well as the dorsum of the feet, and over the sole of both the lower limb. That is for the pain and temperature, pain and touch. The vibration is impaired in the above area on the right side. Left side also, except the chin, it is impaired. Joint sense is impaired in both toes. So where is your localization?
So the power examination part once more, sir.
Yeah, sure. I'll show the power examination. On the left, overall, left lower limb is more weak than the right side. Left limb, all muscles about grade 1 to 2. 0 to grade 1 to 2 approximately, 0 to 1 distally. In the right lower limb, again, all muscles are weak, but much less compared to the left side, say 3 plus to 4. But except the right foot, the dorsiflexion was good power, plantar flexion was weak. See, in the left lower limb, all muscles, including hip flexion, was grade 2. Knee extension flexion, grade 3. Distal muscles, grade 0 to 1. Right lower limb, hip flexion, extension, abduction, adduction, grade 3 plus to 4. Knee extension, grade 4 plus. Knee flexion, 4. Dorsiflexion EHL 5, 4 plus. Plantar flexion, grade 2 to 3. I think I'll show that video, you can get convinced a little bit. And that part I don't have to show. There is a knee extension on the right side. See, the dorsiflexion is good power. Left side 0. EHL is weak on both. Plantar flexion is same, good plantar flexion on the right side. That is good power. So that's the story. Any other clarification?
Still there is
sensations.
Pardon?
Perianal sensations.
Perianal, I did not look because I was in the physiotherapy department doing physiotherapy. So moreover, she's a female, all people are surrounding it. I did not do that. She complained of perianal numbness.
So no UMN features, only LMN features. Wasting, no wasting, sir.
There is wasting, not very prominent, but it's mild wasting is there. Because so duration is only 3 weeks, no? That is maybe the reason why the wasting was not become set in much.
No bladder symptoms at all.
There is bladder symptom. It's got hesitancy as well as overflow incontinence.
So conus cauda and epiconus.
Okay, so epiconus alone, can you explain that?
It is not limited to cauda because hip flexion is also weak. So the lesion is higher up.
Okay. Right. So one is, so you mean to say not cauda equina plus conus, or the lesion is ascending up like that?
still there is a brown second like presentation, sir. Because
It is involving roots
No.
above cauda. Above
Correct.
cauda equina.
Okay, so where do you want to localize?
Could be a meningeal disease.
Pardon?
Meningeal involvement.
Yeah, that's a meningeal disease, a strong possibility. Very good. Then, okay, myelo in the sense that cord plus root, or you can see extensive lower cord lesion, for example, extending from L1 down to S3 can also produce the same thing.
So it's a epiconus lesion. Mainly looks like epiconus lesion.
But if it is epiconus lesion, you can't get in an element type of bladder. Pure epiconus.
The distal weakness pattern is not of a UMN pattern. Because
No,
palmar
it's
flexion is weaker than dorsiflexion.
yeah, of course, that's definitely an element. No doubt about the element. No doubt that S1 root is or S1 segment is more affected than the L5 segment. So, no, so it's not at all human, I agreed with you. Its element is very clear. Okay.
This could be a meninge involvement of a secondary from CA breast.
Yeah, that's also possible, definitely. But only thing is, it's all the roots are affected here. There is no upper limb, no other part is affected. Okay. Now the question is, was it a one is conclusion is element weakness? Was it a pure chordaiconial lesion? Was it a lesion involved in the lower dorsal cord from L1 to S2? Was it a chorda conus lesion or a conus chorda lesion? That is, the lesion need not necessarily be in the chorda icona alone. A conus lesion can go out and compress the chorda icona, but a chorda icona lesion can compress the conus. Okay, in that case, the lesion may be high. Even L1 segment also, L1 root also can be affected. I will show the picture of that thing. Or as Professor was telling, was it a meningeal pathology affecting the chorda icona roots? But not pure chorda icona, going up to involve the upper L1 roots as well. So these are the possibilities which you can think of in this patient. Now, could be anything. But a pure chorda icona lesion is unlikely because pure chorda icona, because chorda icona at the time itself is not very good. We should say always in terms of root. Because chorda icona means below L2, L2 downward. But even also is affected, then what you don't call it chorda icona. Anatomically, you cannot call, but it is, it's illogical to say that chorda icona will not affect L1. Whatever the pathology, if it is ascend up, like a meningeal pathology, can involve the L1 also. But a disease like disc prolapse, if it is compressing the chorda icona L1 root, that is very unlikely to be chorda icona. Because there invariably, there will be compressing the roots as well as the conus. Because above L1, the conus should be compressed. Then it becomes a chorda icona conus lesion. So more likely it will be lumbosacral cord lesion, L1 test 2, a long extensive intramedullary lesion. That's a good possibility. Or a chorda conus lesion, chorda icona lesion compressing the conus. Because initially she had asymmetrical involvement, subsequently bladder became involved. Okay. Now, as the chorda icona is found with the roots of the lower segments of the spinal cord, the clinical presentation of the chorda icona and the lower spinal cord disease are similar. A root lesion can mimic corresponding segmental lesion, but the site of affection is different. For example, a lesion here, S3 to S5 segment, can exactly mimic that of an S3 to S1 root. Lesion may be much lower down. One lesion is at opposite L1 vertebra, that is opposite the S1 vertebra, or somewhere here. All these can produce a similar clinical presentation, but the site of involvement is different. Similarly, lesion from L3 to S5 segments like the long lesion, the lower part of spinal cord, is similar to L3 to L5 lesion. Okay. So it's difficult to differentiate between the two. Unless you find some pyramidal lesion, going panda, that means it's invariably lesion has to be inside the cord. A chorda icona lesion will not produce that. All the things can mimic chorda icona. How will you differentiate a conus lesion from a chorda icona lesion? See, when we say conus lesion, we actually mean an intramedullary lesion of the conus. You cannot have an extramedullary lesion of the conus alone. Why? Because the conus is surrounded by the chorda icona roots. So extramedullary compression of the conus invariably has to be a chorda icona conus lesion. Because all the roots coming from above are all surrounding the conus. So you can't have an extramedullary compression of the conus alone. So whenever it's a pure conus, it has to be intramedullary lesion. So if you're considering an extramedullary lesion, it's not a pure conus lesion because cardiac canal roots are surrounded by the surrounding the root conus. Similarly, the conus lesion may extend upward to the epiconus. Now the lesion progressively involves S2 segment, S1 and L5 segment depending upon the extension. In that case, the lamina lesion will gradually ascend up also. So it no longer become a pure conus epiconus lesion. And the element extends progressively upward even up to the flexus of the hip. So for example, a lesion that started there can go upward up to the L2 and L2 can produce exactly same picture as our patient. Or a lesion extensively involved in the cardiac and roots also can produce, except barring the L1 root. Similarly, it is not necessary that conus lesion need to grow upward always. It can start from epiconus and descend down also. Or it can grow laterally or downwards and implicate the adjacent cardiac canal. Then it becomes a conus cardiac canal lesion. So for example, a lesion there, epiconus, can grow laterally and involve the root and can produce asymmetrical radiculopathy. So it becomes, then we call it as a conus cardiac lesion, conus caudal lesion. Similarly, cardiac lesion can grow upward and compress the conus. Or a vertebral collapse can compress both the conus and roots that form the cardiac vena, which we call it as a cauda conus lesion. For example, a lesion here can grow laterally and compress the medially and compress the conus. Then you call it cauda conus lesion. In such situation, patient can have features of both. The evolution will help you differ. If the first is a root pain, asymmetrical involvement, then developing the conus features, then you think a cauda conus lesion. First thing is a conus lesion like symmetrical saddle anesthesia, bladder. Then the root pain appears asymmetrically. Then you call conus caudal lesion. Imagine a patient who presents with initial bladder affection and saddle anesthesia. Later develop asymmetrical root pain, postural muscle weakness. Then becomes a conus caudal lesion. Then on the other hand, imagine a patient with initial asymmetrical root pain and asymmetrical limb weakness. Say L4, L5 term distribution. Later, after the bladder affection produces saddle anesthesia, it becomes a cauda conus lesion. So our patient can have a cauda conus lesion also, or extensive intramedullary lesion. That's also possible. So in such a situation, one cannot differentiate from an extensive pure cardiac lesion. For example, a lesion there in the cardiac vena compressing the conus will be exactly like this. The presentation is exactly similar. You cannot differentiate the two. Both can produce late bladder involvement. Either late bladder involvement can be due to the root involvement or due to the conus involvement. So both are clinical picture is the same. In such a situation, if you want such a presentation, lesion is more likely to be a cauda conus lesion rather than a pure cardiac lesion because at the level of L1 vertebra, it has to accommodate conus as well as all the cardiac roots surrounding it. So a small compression can compromise the structures because all are tightly packed in that segment, in the canal there. Just below the L1 level, the space is, there's a spacious, when the lumbar canal is very spacious. Only roots are there, no cord. So the roots can easily shift to one side and then it will not be compromised. So this is the point I was trying to set. A small lesion can produce extensive dysfunction. The lesion is set opposite L1. The lesion is compressed, the cardiac canal lesion has to be extensive. So this is the situation now. So where is the lesion in our patient? One possibility is this. It has got extensive endomedullary lesion. Other possibility is a cardiac canal lesion, then it becomes compressed in the conus lesion. Or maybe a meningeal pathology involving only the roots alone, bilateral. Okay, you agree with these possibilities in our patient? All three can present like this. Okay. So what investigation you want?
MRI first, sir.
Okay. MRI, which part? Lumbar spine. Okay. This is MRI T1 sequence. Okay. Then I'll do the other sequences. MRI T2. Sag cut. MRI lumbar spine axial T2. Okay. So anything else you want now? We only scan the caudate vena. The lesion may be inside the cord also, no? Epiconus lesion also is possible. So
Yes, sir.
what do you want now?
Lower dorsal also.
Lower dorsal spine. Okay. So dorsal spine T2 sag.
സ്കാൻ ചെയ്ത റിപ്പോർട്ട് ഉണ്ടെങ്കിൽ കൊണ്ടുവന്നെ ബയോപ്സി
Axial sag.
Dorsal spine.
Okay. So what do you want now?
Contrast, sir, to see root enhancement.
Okay, contrast. The contrast was done. I'll show you that later on. This is the dorsal spine coronal. MRI cervical spine. They will scan the cervical spine. Okay. The contrast, this one you wanted. Then I think I'll show that later on. Anything else you want? Parents was telling about the castamatis, arachnoiditis, meningitis.
CSF,
So,
sir.
yeah, CSF. So CSF was planned, but patient was not willing for CSF study. What else will you want now?
PET, sir.
PET for what?
So we can look for the spinal
Oh,
hyperactive.
that PET scan will not help. You mean FTG PET, no? So therefore,
Yes,
if
sir.
you could, my diffuse distant metastasis it can help, but spinal pathology, I don't know, PET is going to pick up. Vertebral pathology, maybe yes. But there's no vertebral pathology seen in the MRI here. Anything else you want?
Nerve condition study, sir.
Nerve conduction study. Okay. That was not done. Because I didn't think it's a peripheral neuropathy problem at all. It's clearly bladder is affected. So caudate vena. So I didn't think that it is required. That is why I didn't do the nerve conduction.
Roots were little clumped, no, sir.
Okay. So what do you want now?
Clumping of the contrast.
I did MRI of the brain. Why?
Drop, to look for drop med, sir.
Exactly. Now see the picture now. The same picture I showed earlier. What did you see there? You got to drop metastasis. See that Also the picture. See the see the dot-like hypointensity. Did you see that? Those things which are there is drop metastasis. I'll static filament. So this is the one. And as Feroz is telling, there are some other roads that clumped. Pardon?
Lower dorsal also there was one spot-like lesion, sir.
Lower dorsal I did not see. I'll check that thing. So this is the clear, see that some rounded hypointent. This is how drop metastasis appears. And you can also find some clumped roots lower down there. Above also it is there, but more prominent there. There is no why there should be hypointensity like that. This is MRI brain done. This is the diffusion. Not very, it's not show anything. T1. Contrast. That may be artifact, we are not sure. Here you find something. Enhancing lesion in the Sylvian fissure. The contrast picture I will show once again. That's the one you can see there. Side cut also you can make out that lesion in the Sylvian fissure. So spine MRI, sagittal cut, contrast. You can see diffuse enhancement of the clumping of the roots enhancement. This is the, I will show you a little more better picture later on. This is another sagittal cut. This is enhancement is seen. It is clumped together and enhancement is seen there. And axial cut I will show you the patchy enhancement. This is axial. I think I'll show a better axial now. This axial you can see. See the roots are enhancing. These are all enhanced roots which normally should be not enhancing. Dark. Here all roots are all enhancing. This enhancement, the nerve roots you can see there. Again, roots enhancement. The coronal cut, the coronal sagittal also you can make out the linear enhancement there. So that's a diagnosis. Drop metastasis from carcinomatous meningitis. No, the point why both the cases, as far as is pointed out, if you look very carefully at the T2 sequence, you can find that T2 hypointense lesions are joining, surrounding or attached to the nerve roots. That was the clue to suspect a drop metastasis. That one. These dot-like things. Okay, any questions? Okay, shall I go to the next case then? Okay, next case.
Yes, sir.
Okay.
Sir, if the patient is willing for CSF, sir,
No. In fact, what happened after the contrast study, I did not do the CSF because even before that, because drop metastasis was seen, contrast was clearly suggestive of that. So I sent out, no doubt about the diagnosis, I sent to RCC where the patient was being treated earlier. But he's got a brain metastasis and also got multiple clumped root, but no other things we can think of.
Yes, sir.
Now I'll go to the next case. Two short cases. Not too short case, then relatively short. This is a story of a 24-year-old lady. 1 month back, she noticed pain in the medial aspect of the foot below the medial malleolus, which is more for the last 1 week. If she touches below the medial malleolus, she gets shooting pain along the foot. She noticed this for the last 2 weeks. For the last 10 days, she noticed numbness over the lateral part of the sole. So this is the only one. So 1 month back, she noticed pain in the middle part of the foot. If she touches the middle part, she gets a shooting pain. For 10 days, she noticed numbness of the lateral part of the sole. So on examination, hip flexion is normal, knee extension normal, hip adduction normal, hip flexion normal, dorsiflexion is normal bilaterally, EHL is also normal bilaterally, but plantar flexion was normal. Flexor hallucis is long as normal. But you find that some gap is increased between the big toe and the second toe. See, gap on the left side. Adductor hallucis is weak on the left side. There's also increased gap between the two. The introsea also appeared weak on the left side. Difficulty to introsea the foot and still is apparently less. The abductor hallucis is normal. That's also normal power. Only the adductor hallucis is weak. Reflexes just elicitable. Angle check also just elicitable. Tenderness, she's got tenderness below the middle malleolus. That pain is equal on both sides. Lateral part of the foot is okay.
Side feel ആവുത്
He's able to feel.
ഇത് ഫീൽ ആവുത് ഇത്
Yeah, she's not able to feel on the lateral side of the little toe. She's not able to feel there.
നമ്പർ ഇത് നല്ല തെരിയുന്നില്ല
Medial part is okay.
ഇതോ
Lateral part of the sole she's not able to feel.
തെരിയില്ല തെരിയുമ്പോ ചൊല്ലണേ
I'm moving her lateral to medial. She's middle part of the sole she's able to feel.
തെരിയുമ്പോ ചൊല്ലണം തെരിയുത് ഇങ്ങെല്ലാം തെരിയുത് ഇങ്ങ തെരിയില്ല ഇത് തെരിയുതാ
Over the calcaneum also she's normal.
തെരിയുന്നില്ല ഇത് തെരിയുതാ തെരിയുത്
Vibration is impaired over the little toe. Normal on the right side. Joint sense is normal on the right side.
ഇപ്പൊ எப்படி தெரியாது
She does not know.
தெரியல
She does not know. SLR is negative. She can stand on heel and toes. So findings confined left lower limb. There is increased gap between the big toe and the second toe compared to the right side, right foot. Power weakness of adductor hallucis and introsea of the left foot. Normal power of the abductor hallucis, EHL, and flexor hallucis longus of the foot. Dorsiflexion, plantar flexion of the foot normal. She can stand on toes. All of the muscles were normal. DTR all normal. Sensory system impaired pain over the lateral part of the sole, over the lateral surface of the little toe. Normal over the rest of the sole and over the calcaneum. The lateral part of the little toe as well as the lateral part of the sole, it is impaired. Vibration normal on all toes except the little finger. So I forgot to mention that. And impaired JPS over the left little toe. No sensory loss over the calcaneum. SLR negative. Tenderness over the middle part of the angle below the middle malleolus. So where is a localization and likely etiology in this patient?
Tarsal tunnel syndrome.
Okay, tarsal. Which structure is affected? That's the thing.
Posterior nerve below the tarsal tunnel. Lateral plantar branch.
Okay, it's a lateral plantar now. You have to specifically say that because medial plantar is not affected. Why medial plantar is not affected?
Sensation of the medial aspect of soleus.
Right. Very good. So which nerve is lateral plantar? Tarsal center. Okay. Now questions to you one. Why the adductor hallucis is weak at the same time abductor hallucis is normal?
Adductor is supplied by the lateral plantar nerve, sir.
Yeah. Whereas abductor is supplied by the
Medial plantar.
medial plantar. So that answers the question. Very good. Why is the sensory loss of the lateral side of the little toe?
That can be explained by the lateral plantar nerves only. Lateral plantar nerves.
But at the same time, sensation of the lateral part of the sole is normal. So lateral part is all normal except the little toe, she's not able to feel. All other parts she's able to feel.
Sural nerve
B
supplies.
branch of plantar nerve.
Sural nerve supplies there.
That's a supply by the sural nerve. Very good. Why sensation of the calcaneum is spared?
Medial calcaneal nerve is there's a branch. Medial calcaneal branch is expired.
Medial lateral calcaneum is above that thing. It's arising above the medial lateral plantar nerve. One above the retinaculum, one below the retinaculum, but it's above the division. So that's the answer. So I'll show the anatomy of that thing. The green is the supply of the sensory supply of the lateral plantar nerve. The blue is the medial plantar nerve. The magenta medial calcaneal nerve, and sural nerve the lateral part of the foot. It can extend up to the little toe. Now I think they'll skip all. And again, the middle, well, calcaneum is paired because the calcaneum is supplied by the medial and lateral inferior and medial calcaneal nerve, one arising above the flexor retinaculum, other just behind the retinaculum. So if you look at the motor supply of the plantar nerves, the medial plantar nerve supplies the abductor hallucis, flexor digitorum brevis, flexor hallucis brevis, and the first umbilicus muscles. All of this is supplied by the lateral plantar. Lateral plantar is just like a ulnar nerve in the hand. Okay, then more motor muscles are supplied by the muscles are supplied by the ulnar nerve in the hand. Only thenar is supplied by the median nerve, but the sensory is more for median because median is supplying 2.5 fingers, ulnar only 1.5 fingers. Similarly, here lateral plantar motor supply is more, but the sensory supply is less. Only medial 1/3 of the lateral 1/3 of the sole. Lateral plantar nerve supplies the remaining intrinsic foot muscles, including quadratus plantae, abductor digitae minimi, flexor digitae minimi brevis, adductor hallucis, and second through all other intrusiae and umbilicals are supplied by the lateral plantar nerve. So what test you need now? You have to confirm, no?
NCS.
Okay, NCS must have. This is NCS. Peroneal normal. Tibial adductor hallucis pickup is also normal. Abductor hallucis. Sensory normal. Superficial wave normal. What else is a normal conduction done? What else you want now?
Tarsal tunnel protocol, sir. We have to
Yeah,
separately do it.
very good, very good. So snap from medial lateral plantar nerves. See what is happening now? The lateral plantar nerve potential is nil. Medial plantar over the sole is on the left side is present. So they clearly tell you that patient's got an axonopathy of the left lateral plantar nerve. Okay. Because we normally don't do a pickup from the adductor hallucis. It will be very difficult. But abductor hallucis is easy. That is a normal conduction. You cannot pick up we can only pick up if the medial plantar is affected, where the AH, the potential of the abductor hallucis will be decreased. If lateral plantar alone is affected, the conduction from the foot will be, motor control will be generally normal, because we don't pick up from the adductor hallucis. It is difficult, it's inside. Okay, so we have proved it's lateral plantar. So what else you need?
Ultrasound, sir. Ultrasound of the tarsal tunnel, sir.
To look for what, any ganglion or something like that? Okay,
Yeah,
so
neurofibroma or what
fibroma.
is
Okay,
causing the
okay,
compression?
okay. So what we did was I did an MRI of the ankle and see the finding in the MRI. It will be difficult one to understand, but I will explain it later on. This is the angle sage cut. You can see long hyperdensity. You can see some areas beaded there. It's along the posterior tibia now, and that hyperdensity is reaching towards lateral plantar now.
Main thing, that's the main part.
Therefore, entire length is hypertension. In the nerve, maybe outside the nerve, some of the part is beaded and it's encroaching, reaching to the lateral plantar. Any idea what this condition could be?
Is it a leprosy, sir?
It could be leprosy, or discovered. It could be leprosy, cannot along. But posterior tibial is the rarest nerve to be affected in. It's not a superficial nerve; it's a deep nerve. Conperonal is more commonly affected in Hansen disease. Now I'll show this thing. This is called intraneuronal ganglion cyst. The one which is coming down like that. That's the entire length of the ganglion. I'll tell you what about this. This is later on. So this is the ganglion cyst, and you can find some showing the beaded appearance of the ganglion. Some of the project like a beads like that. And the ganglion is entering the lateral division of the posterior tibial nerve. That is, the lateral plantar nerve is affected maximally. Now this is other cut which showing the location of the nerve. The dark one enter is the nerve, and the white one is a ganglion cyst. That one you see there is a cyst. And the dark one is the nerve.
That's cyst.
The white one surrounding is the vein. I'll show this thing. This is the entire thing is the posterior tibial nerve, the one black thing. The white thing rounded inside is the ganglion cyst within the nerve. And the two adjoining white things you see are the veins and not part of the nerve. Nerve appears dark. This again you can see that that ganglion cyst inside, and it's a branching inside.
Okay.
You can see branch inside the nerve. Interneural ganglion cyst and showing the branching. This is again another picture showing that ganglion cyst part. That one. Now, if you look at the muscle atrophy, see what you see that is the abductor hallucis. Medial to that is the quadratus plantae, which is nerve, and the abductor digiti minimi is also denerved. That's it becomes hyper intense. So this is the normal abductor hallucis. This is the atrophied quadratus plantae. Again, that is the atrophied abductor digiti minimi. So all pointing to involvement of the lateral plantar nerve, because abductor hallucis is separated by the medial plantar. All of the muscles are separated by the lateral plantar nerve. Again, in the sagittal cut, you can make out that is abductor hallucis. The one is below is the quadratus plantae. Medialmost is abductor digiti minimi, lateralmost. This is the dark one is the normal muscle. That is subject hallucis. That is the quadratus plantaris is atrophied because hyperintense. That is subject digiti minimi atrophied mainly that's on the lateral side. So patients submit for aspiration. The aspiration is not working. The plan is to do surgery. And tell you about this ganglionosis later on. So, this is one of the etiology you always keep in mind, can present with a nerve palsy. And treatment is surgical. Now, I'll show you another case. The story of a 23-year-old female. Her complaint started 2 months back as pain in the right side of the knee region, which later on ascended up to the hip and down the ankle on the right side. The pain was more on standing and walking, less on sitting. The pain did not increase by coughing or sneezing. 3 weeks back, she noticed numbness of the web space between the big toe and the second toe, and complete foot drop. So the story started as pain in the right side of the knee region, which subsequently ascended up to the hip and down the ankle. Pain is more on standing and walking. Pain did not increase by coughing and sneezing. 3 weeks back, she noticed numbness over the web space between the big toe and the second toe and complete foot drop. So this is the patient's examination. Hip flexion was normal. 0 for plexus. Tibialis anterior was also causally weak. She cannot even keep it dorsiflex in the inverted position. 0 power. EHL is also 0 on the right side. Inversion about the plantar position is normal. Medialis position is normal. Inversion is also weak, or 0 to 1. Plantar flexion 1. Flexor is normal. Hip flexion is normal. Hip abduction normal. Knee jerk normally illicit. Ankle jerk is also normal. The sensation, and that's the area where the sensory loss, only on that area. There is able to feel. The middle part is normal, web space is affected. So, weakness of grade 0 to 1 for the tibialis anterior, extensor digitorum, and extensor hallucis longus. Grade 1 to 2 for the inverters, plantar flexus, flexor hallucis longus, hip abductor is normal. Detail all normal, plantar flexor. Sensory dulling in the web space between the big toe and the second toe and adjoining areas of the big toe and second toe. So where is the localization?
Deep peroneal nerve, sir.
But inverters are also weak.
Common peroneal.
So it's a common peroneal, but the sensory part is mainly on the deep peroneal. Okay. So common peroneal is less affected. Main brunt was in the deep peroneal. So there's not a common sort of compression of the common peroneal nerve there, but some peculiarities there. Because usually in common peroneal pressure pulse, you get sensory dulling over the lateral aspect of the leg also. Here it's only on the tibial, the anterior nerve, sensory loss. Okay, so investigations, nerve conduction shows ADP is low amplitude. Sensory potential is normal. Why normal? Because superior peroneal is separated by the superior peroneal part of it. That is less affected. FA again absent, EDB is absent, so FA is also absent. So the EMG from the both the thing, the TB and the PEEP both show innervation. LS spine normal. Now, what is it? What else you want now? Is it a pressure palsy? Right, to put the patient steroid.
MRI,
MRI, which part?
MRI knee.
Okay. That this case I had shown earlier, but this is a similar case. I thought I'll bring that case. Now, what is the peculiarity to the CPN palsy? Predominant affection of the anterior tibial compartment. So look at the MRI here. You very carefully look at the MRI. This is going above downwards. This look at the hyperdense rounded thing here on the medial aspect. And here again, there is two areas, hyperdensity and horizontal branch, horizontal division of this hyperdensity. I'll explain it later on. Okay. This is the coronal. That is a vessel. You can see long hyperdense lesion along the conperoneal nerve, the one which you see there. This is intraneuronal ganglion system conperoneal nerve. Just like what you see in the posterior tibial, this is intraneuronal ganglion system of the conperoneal. I will explain how it is produced. About 20% of the so-called pressure palsy are actually due to this cyst. Now what happens is the conperoneal is coming like that. It is going below the tendon of the superficial peroneus longus muscle and divides into first the superficial peroneal nerve, then goes the deep peroneal nerve, supplies the muscle anterior tibial compartment. This is the peroneus longus. Then gives the articular branch. This articular branch which gives the fibulotibial joint, tibiofibular joint. Now here is the pathology starting from the joint here in our patient. Now what happens is that from the joint, that this is the tibiofibular joint, the synovial fluid escape into the articular branch. From the tibiofibular joint, escapes through the whole of the joint capsule and form a cyst. As you know, the articular branch supplies the joint. The fluid escaping, if the fluid is escaping where the articular branch is entering the capsule, like here, entering the capsule, the fluid can then enter into the nerve and can travel along the length of the nerve, causing the intraneuronal peroneal cyst. That is, this synovial fluid form a cyst and can travel along the nerve. The nerve is coming from above downward, and this articular branch, this is the deep branch, the superficial branch. Since it is coming through the articular branch, that will be the first area to be involved, and then progress retrograde through the nerve and reach the conperoneal nerve. So again, showing this from the literature, this starts here and goes like that, like a U shape. Okay, and this is the deep peroneal, and this is superficial peroneal. If the cyst has to implicate the first one, apart from the articular branch, should be the deep peroneal. Then only the superficial peroneal is getting affected. Because lesion is not from here, it's from here it's proceeding. This is another one. So look at the radiology now, which I have shown. Again, to think that from below downward, each cut. This is the first one. Then the second one. Third cut, both the descending branch as well as ascending articular branch. Then the horizontal segment again, there is a horizontal segment. And then ultimately, it encasing the anterior tibial nerve, the deep peroneal nerve. Also, this is the picture showing that this is the articular branch, comes down like that and join the conperoneal nerve. This is the conperoneal nerve, which gives articular branch first, then the posterior superficial peroneal and the deep peroneal. That is, first is a peroneus longus, then superficial peroneal, then deep peroneal, then articular. That is the order in which the nerve arises. But here the fluid is coming from here. So the first affecting articular branch, then deep peroneal, then only the superficial peroneal. Now let us see the corresponding cut I will show you. This is the way it goes. Now this is the first one. The cut is like that. The corresponding, I look at the diagram on the right side. The second one below that level. Third one, there is one hyperdensity there. That is because of that the descending branch. Then the other one, the ascending branch of that's articular branch, ascending articular branch. Then again, you can see the descending branch here and the ascending branch. You can see the corresponding descending ascending branch. Then this is the horizontal segment of the articular branch that appears horizontal, entire length is hyperintense. That is a horizontal segment of the articular branch. Then what happened? It enters the anterior tibial nerve. That is the area which is shown. That's why appendicitis is seen in the cut. So corresponding MRI and the corresponding the cytopathology in the nerve. Again, the another axial cut showing the intraneural ganglion cells in the anterior tibial nerve entering into the anterior tibial nerve, and the anterior compartment muscles are more hyperintense, more affected than the peroneal compartment. Anterior compartment muscles. This is again the sagittal cut showing the cyst along the peroneal nerve. Why the anterior compartment prominence due to? Because the fluid which enters through the articular branch subsequently enters the first branch, that is the deep branch. That it reaches come here and reaches the first branch, that is a deep branch. That is the deep peroneal compartment is more affected than the superficial peroneal compartment. This is again literature. Features that may suggest intraneural cyst, acute onset, deep peroneal predominance, dorsiflexion weaker than the version, fluctuating symptoms, palpable mass around the fibula head. So that's the story. So these two cases both are peroneal intraneural ganglion cyst arising from the synovial joint of the joint capsule and then leaking into the nerve, forming a cyst. This second case is from the Calicut. He reported to me, I forgot. And he was operated and he became all right. That lady became completely all right.
But this girl is only 24, no, sir? Can
24.
this age?
Yeah, any age can occur, any age. This girl is 24, the other also is 24, somewhere in that younger age group.
So this is not due to any degeneration. This is
No, nothing. It's because the cyst encroaching into the nerve. It can be inside the nerve. The cyst can be outside the nerve in the epineural region also it can occur. Any questions? എന്നൊരു 5 മിനിറ്റ് കഴിഞ്ഞ് വിളിക്കണേ 10 കഴിഞ്ഞ് വിളിക്കേ മീറ്റിംഗില്ല
Surgery, will it cause any nerve damage?
No, what they do is they won't go nerve damage because the nerve fibers are longitudinally oriented. No, they only they don't cut the nerve. They only will slit along the direction of the nerve fibers. To relieve the fluid from inside the cyst. They don't take out the cyst.
Will that recur, sir?
Usually no. That's what I don't have much experience. This is the second case I'm seeing. So what the literature says is a good prognosis after surgery. It will not recur. Okay. Shall we close? Yeah, please.
Yes, sir.
Yeah. Okay then. Okay then. See you next week. Good
Thank
night.
you, sir. Good night, sir.
Good night, sir. Good night. Thank you, sir.
Okay,
Thank
sir.
you.
Thank you, sir. Good night, sir.
Good night, sir.
Right, sir. Thank you.
Good night. Good night. Good night. Good night.
Happy Onam, sir. Happy Onam.